Hello, welcome everyone. Thanks for joining me for this session of MRC Psych Paper B revision. And this is Pass Appraisal course, and I am Lena Palaniappan. In this session, I'm going to talk about bias in clinical trials and reporting standards in clinical research. We are going to see Paper B MRC Psych questions that have appeared in the last 5 years in this topic in the next 1 hour. Please note that reproducing this material is prohibited. This material is copyrighted, both the videos and also the PDF study materials that you received along with this course material. All of them are copyrighted. Please do not share them without our permission. This material is provided only for you to use for educational purposes to pass the MRC Psych Paper B exam. You cannot share this with anyone else without our permission. Please respect our right to be compensated for our time and our efforts. Thank you. In this session, I'm going to talk about bias and different types of bias. I will also explain fallacies in research. We will also see reporting guidelines for various studies, and we will solve long SBA type questions on socioeconomic status and mental disorders, inequality and mental illnesses. We will also see levels of evidence and gray literature related topics. We will also see various guidelines, as I mentioned earlier. All of these questions have appeared in your previous paper B exams. And for this session, to prepare for this session, I would like you to go through 2 PDF notes, one on bias and the other on recommendations and guidelines. You could get these notes through the Smart Revise revision notes in SPMM. You can also get them through Pass Appraisal website, where these are called quick revise notes. Okay, in this first session, we're going to talk about different MCQs that have appeared in the topic of bias in clinical studies. In a cohort study of cigarette smoking and cognitive impairment in older adults, 42% of subjects are lost to follow-up after 5 years. Select the most likely form of bias or error. A. Attrition bias. B. Confounding. C. Ecological fallacy. D. Information bias. E. Random error. It's important to note that even though we prefer prospective studies whenever possible, whenever we have resources, prospective cohort studies are quite expensive both in terms of cost and time. They also have weak power to examine rare outcomes. You need to assemble a very large sample of exposed people in order to study rare outcomes. So when it comes to rare outcomes, case control studies are better off than cohort studies. Attrition bias is an important bias with prospective design. It happens because of dropouts. Attrition bias worsens when you have a very long period of follow-up. So the longer the period of follow-up, worse the attrition bias becomes. Exposure effect on attrition may lead to differential loss between the two groups. That's when we worry about a bias. If two groups have the two groups that you compare, if they show differential pattern of loss to follow-up, and if that differential pattern is related to the exposure itself, then this will introduce a strong bias, and that's called attrition bias. So in this question, 42% subjects are lost to follow-up after 5 years. You are doing a cohort study, so this is attrition bias. A population study shows that in parts of Ireland, Catholic districts have a significantly higher rate of suicide than Protestant districts. The researcher concludes that Catholic concepts are associated with suicide. Which of the following phenomena has happened? Selection bias, ecological fallacy, measurement bias, triangulation, allocation, concealment. Ecological fallacy is the error of making individual level inferences from group level observations. Take this for example, this picture. I have plotted 4 districts with different percentage of Protestants. And you can see I have also plotted percentage of suicides. So with more number of Protestants and more number of Catholics, you see higher number of suicides here. This is what is reported in this study. But when you look at individuals within these clusters, within these districts, then you don't see any correlation. So look at this scatter here. This scatter has no correlation within itself. In fact, there is no linear trend, positive or negative. It's just a zero correlation. So within each district, the correlation is zero. But because the mean number of suicides itself vary among districts, you see a pseudo correlation, and this effect is sometimes called ecological fallacy. So making individual inferences from group level data is always problematic, and if you do that on the basis of an association study relating two variables, then you will be getting into the error of ecological fallacy. Ecological fallacy is the right answer for this question. A case control study was designed to determine whether selected alleles at one locus are risk factors for anorexia nervosa. One of the alleles is found more frequently among those in a particular ethnic group. This group also has high rates of anorexia nervosa in the study. Which of the following is the best explanation? Attrition, confounding, misclassification, reporting bias, selection bias. What is a confounder? Confounder is a variable, it's a third variable that's related to both the cause and the effect that you are studying, but it is not on the causal pathway. Now, genetic risk is the presumed cause, and it produces the outcome, that is anorexia in this scenario. Ethnicity is also a known risk factor for anorexia. Okay, ethnicity is also associated with genetic risk. The allele representation is different in one ethnic group. So you are having a relationship between the cause and the mediator, confounder, and you also have a relationship between the effect and the confounder, but cause is not influencing the effect through the confounder. It's not on the causal pathway. So in this situation, we can call this as confounding bias. Which of the following statistical methods do not adjust for potential confounding variables? Least squares method, Mantel-Haenszel test, multiple regression, ANCOVA, stratification. There is one slide I want you to really keep in memory. This is a slide on dealing with confounders. The effect of confounders can be reduced by using various methods. Now, common method we use is at the time of sampling, we restrict people with a certain characteristics. So anybody with a high level of confounder would be restricted from the study. We can also do matching. For every person with a confounding variable in group A, you find another person in group B who has the same confounding variable in the same dose. That's called matching. By doing so, you will even out the confounders distribution in the two groups. When the confounder is equally distributed, you don't have to worry about it. Minimization is another method which is in between matching and randomization. Randomization, you know what randomization is. It is randomly choosing a sample from a larger frame of sample, and this will ensure that any confounder, known or unknown, gets randomly distributed between the two groups. So these are all methods you can use during recruitment. You can also plan to do a stratified analysis at the time of recruitment, or you can do a stratified recruitment itself. And statistically speaking, you can do an adjustment. You can also use multivariate statistical methods like multiple regression and ANCOVA. Mantel-Haenszel method is a non-regression method, but it is used to produce summary risk. That is, it's used to do adjustment after you do stratification. So among all those listed here, least squares is a method for assessing goodness of fit between just two variables. If you're only dealing with two variables where you don't have place for third variable, you're not doing multivariate statistics. You're only doing bivariate statistics. In this case, you cannot rule out a confounder. Least squares method is not used for ruling out confounders. The answer for this question is A, least squares method. Okay, so we now see an EMI here. You have choices between A and G, various types of biases given, and you have three questions. Intention to treat analysis aims to eliminate this bias. Which bias is eliminated by intention to treat analysis? Aims to eliminate which bias? Blinding reduces this bias. That's question 2. Cohort studies are especially prone to this bias. That's question 3. So dropouts are included in the final analysis when ITT principle is employed. So if you have attrition, then you are able to mitigate the effect of attrition by including those dropouts in the final analysis when you use intention to treat approach. So first question, the answer is A, attrition bias. That's what you mitigate by using ITT. The primary goal of blinding is to reduce measurement bias. You don't want the patients to report the outcome differently just because they know they are taking particular drug. Same way, you don't want clinicians to also misjudge the outcome because they know what drug the patient is taking. So blinding is done primarily to reduce this measurement bias. So 2 answer is measurement bias. 3. Cohort studies are especially prone to this bias. Uh, Cohort studies are especially prone to attrition bias. Remember that. Recall bias is more common in case control design. So question number 3, attrition bias will be common for cohort studies. A, D and A, those are the correct answers. Okay, in this session we're going to talk about MCQs and EMIs and also long SBAs that have come up in the area of reporting clinical studies. There are certain standards that you have to follow when you report clinical research, and questions have been often asked in this area in the last 2 years of your paper B exam. In fact, this table that you see here is a summary of different reporting guidelines. When you have some time, please revise what is shown in this table. Question 1. Which of the following is required when reporting the conduct and results of an RCT using the flowchart recommended by the consort guidelines? Number of dropouts, number needed to treat, intention to treat, number of days of non-compliance, number of clinical assessments. So this is a consort diagram. Consort statement is an evidence-based minimum set recommendation for reporting randomized controlled trials. It offers a standard way for people who do randomized controlled studies to prepare reports of the findings of the study, and also it helps them to provide a complete and transparent reporting of the study. For the readers, such as ourselves, it helps to do a critical appraisal and also interpret the way the study has been conducted. So it gives you an idea of the research methodology. It also helps to understand if there is any possibility of attrition bias, because one of the main thing you report in a consort diagram is number of people who drop out from each arm, and you also depict the reasons why people drop out. That helps you to understand if there could be some attrition bias in the conduct of the study. So the answer is number of dropouts. That's an important information to be reported when you do a consort diagram. Next question is an EMI. Sources of medical evidence. This has 2 parts. The first part, choose the most appropriate resource to access research literature from the above list. Number 1, to identify the recommended practice of occupational therapists when accepting referrals for PTSD. Number 2, to identify guidelines on treatment of new onset adolescent depression. Number 3, to identify the evidence reviewing a particular treatment option for cardiac failure in geriatric population. Okay, so let's first look at different databases. CINAHL, CINAHL is Cumulative Index to Nursing and Allied Health Literature. So remember, AHL stands for Allied Health Literature. It's an authoritative source of information for nurses and our allied health professionals, including OTs and others interested in healthcare. Cochrane Library maintains the Cochrane database of systematic reviews. This is the leading source of systematic reviews in healthcare, and this is across all disciplines. Systematic reviews are widely accepted as the gold standard resource in terms of evidence-based healthcare information. So Cochrane also maintains a separate trial register. Apart from the systematic review registry, it also has a separate trial registry. So here, question 1, to identify the recommended practice of occupational therapists when accepting referrals for PTSD, you will search papers from the CINAHL database, the database for allied health professionals. To identify guidelines on treatment of new onset adolescent depression. So if you want to look for guidelines in the UK, the place to go to is NICE. NICE guidelines is what most people use in the UK. So National Institute of Clinical and Healthcare Excellence, that is NICE. You will look for NICE guidelines for question number 2. Question 3, to identify the evidence reviewing a particular treatment option for cardiac failure in geriatric population. So if you want to review particular treatment option, you should first check if Cochrane has done a review. So Cochrane reviews is the place to go for question 3. So this is the second part of the same EMI. Here we have to answer 3 questions again. Number 1, to identify the dominant psychoanalyst viewpoint of borderline personality disorder that existed in the 1870s in the United States of America. So you want to look for papers reporting on borderline personality in the time around the time 1870s. So this is nearly more than a century and 1.5 century back. So you want to go back 150 years to find what was the literature reported. Number 2, you want to identify a recent trial that compares the effectiveness of a new drug with an established drug. So you want to look for new information in the second question. Third question, You want to locate a conference abstract reporting highly controversial but novel findings on language development. So these are the three issues you have. Let's first talk about SIGL. What is SIGL? SIGLE. SIGL is the System for Information on Grey Literature in Europe. SIGL is an European initiative operated by a network of national information and document supply centers. What do? They actively collect and promote grey literature. What is grey literature? These include things like conference abstracts, doctoral thesis, and also other academic works that are not published in the form of a paper or a report. These are usually available if you seek them. They are not indexed in big databases. The only place where we can have a reasonable index of this grey literature is SIGL in the Europe. What is PsycInfo? It's a database that contains publications from more than 50 countries, and it has journals from 29 languages. And the most important part of PsycInfo is it's probably one of the databases that holds very old data. So you have classic books in psychology from the 20th century and even some books from 1840 onwards in this collection of PsycInfo. So if you want to look for old information around 1870s, if you want to look for something, then PsycInfo is a good place to go to. Okay, so let's see the answers for this question. If you want to understand the dominant psychoanalyst viewpoint on borderline personality in 1870s, you better go to PsycInfo. To identify a recent trial comparing a new drug with established drug, you could use a PubMed. PubMed will publish all the recent papers, so you'll be able to look at PubMed for this recent trial. If you want to locate a conference abstract, the place that you want to go to is SIGL, S-I-G-L-E. So answers are shown in this slide. Next question, reporting guidelines for clinical studies. This is also an EMI. Choose the most appropriate recommendation to report research studies from the above list. Reporting meta-analysis of clinical RCTs. Which reporting guidelines would you choose? Reporting cohort studies. Reporting systematic reviews. PRISMA. PRISMA stands for Preferred Reporting Items for Systematic Reviews and Meta-Analysis. This is to help authors report a wide array of systematic reviews to assess the benefits and harms of healthcare intervention. So remember PRISMA for systematic reviews, meta-analysis. CONSORT. CONSORT is probably one of the most well-known flowcharts that we have when it comes to reporting studies. It stands for Consolidated Standards of Reporting Trials, and this was developed by a group of scientists and editors who got together to improve the quality of RCT reporting. Quorum. Quorum stands for Quality of Reporting of Meta-Analysis. There was a conference convened to develop these standards long ago, and this mainly is based on reporting meta-analysis of clinical randomized control trials. So RCT meta-analysis, you could use Quorum. STAR-D stands for Standards for Reporting Diagnostic Accuracy. This helps to improve the reporting of the studies that present results of diagnostic accuracy. So screening test results, studies comparing gold standard with reference with a new test. All of these studies could be reported using STAR-D, and this is a slide showing a checklist for STAR-D. What are the different things that we need to report? STROBE stands for Strengthening the Reporting of Observational Studies in Epidemiology. So this is a good checklist for preparing papers on observational studies. That includes cohort, case control, and cross-sectional studies. MOVE stands for Meta-Analysis of Observational Studies in Epidemiology. This statement is intended for helping people who report meta-analysis of observational studies. COREC stands for Consolidated Criteria for Reporting Qualitative Research. And this is a 32-item checklist for interviewers and also for focus groups. Okay, so coming to our own questions, reporting of meta-analysis of clinical RCTs, you could use Quorum. Reporting cohort studies, you could use STROBE. Reporting systematic reviews, you could use PRISMA. Okay, so the answers are Quorum, STROBE, and PRISMA. In the hierarchy of evidence-based medicine, the grade conferred to expert consensus statements is 1, 2, 3, 4, or 5. So this is the hierarchy of evidence-based medicine. You start with ideas, opinions, case series, case reports, so on and so forth. You also see various forms of this pyramid. There are various other forms available as well. But for our purposes, that's good enough. So the grade conferred to expert consensus statement is right at the bottom. So it's probably the largest number that you see here. You should report that, grade 5. Hello, welcome back. In this session, I'm going to take you through a long SBA that has appeared at least 3 times now in the last 3 years. This is a question from an editorial published in the British Journal of Psychiatry. It was published in 2010. This is from Kate Pickett and Richard Wilkinson. And this editorial had a graph attached to it, and the graph was given to you in the exam. And you also had a paragraph attached to the graph, very short paragraph. So let's quickly go through that. The data on the prevalence of mental illness in the World Health Organization surveys was used to investigate the impact of income equality on health. Attached figure shows association in 12 countries between income inequality and proportion of adults who have been mentally ill in the 12 months prior to being interviewed. So this is the relationship between income inequality and percentage of people with mental illness, adults with mental illness. And you have 12 countries which are plotted here. Let's see what are the questions that come up. The first question, what can you say about the attached graph? It is a prevalence chart, cost benefit plot, cost effectiveness curve, population pyramid, scatter plot. So these are some of the examples of a scatter plot. A scatter plot is a graph with two axes, x and y axis, and the x-axis and y-axis, both of them contain two different variables, mostly continuous variables. And if you have a trend like this, the first figure that you see here, it's called positive correlation. If you have a downward trend, it's negative correlation. If the scatter is all over the place, it's a lack of correlation or no correlation. So this is how we interpret a scatter plot. What you have here in this question is a scatter plot, because you are plotting two variables x and y against each other, and you're getting a linear function. What can you conclude from the above graph? Countries with higher income inequality have higher rates of mental illness. Countries with higher income rates have higher rates of mental illness. Income inequality causes mental illness across different countries. Higher rates of mental illness across different countries cause income inequality. Poverty is directly related to global rates of mental illness. What can you conclude? Now, correlation does not suggest causation, so you cannot make any causal statement. So both statement C and statement D can be taken away. Income inequality causes mental illness causes income inequality. Both of them can be taken away. So A, B, and E are the ones that are worthy of examination. So what does this graph really show you? It shows you that higher the income inequality, so this is low, this is high. As you move along the x-axis, higher the income inequality, you are also moving along the y-axis, higher the percentage with any mental illness. So we could say, so that's the trend. We could say countries with higher income inequality have higher rates of mental illness. So this is an observation that we make. We cannot make any causal inferences from this. It's only a correlation. So A is the right answer. Which one of the following countries can be identified as an outlier in the above graph? Germany, Italy, Japan, Spain, USA. Well, what is an outlier? Outlier is a data point that lies outside of the general trend. So you can see the general trend here is everything is close to this line, straight line here. Okay, USA, Japan, everything is close, or they are very in fit. Well, they have a goodness of fit. They have a good fit with the a line that we show here. So what are the data points that do not show a good fit with the line that is shown? Italy, Spain, both of them are far away from this line. The further away from this line you are, the more outlier you are. So the answer for this is Italy. Which one of the following types of errors is most likely to influence the interpretation of the above study? Attrition bias, ecological fallacy, incidence prevalence bias, publication bias, recall bias. Ecological fallacy is the error of making individual level inferences from group level observations. So if you what you see here is countries, you see a trend across the countries, but within each country there may not be any relationship between income inequality and distribution of mental illness. So we don't know that if there is a direct link is present at an individual level within each country, but across countries we are seeing a pattern. So this is an ecological observation, and you are prone to make an ecological fallacy if you try to extrapolate this to an individual level. Okay, so the answer is ecological fallacy. Okay, welcome back. In this session, I'm going to take you through a long SBA on socioeconomic position and common mental disorders. This paper was published in 2006 in British Journal of Psychiatry by Ricardo Araya and others from Bristol. In your exam, they give you a large paragraph on socioeconomic status and mental health, and this was followed by a table. So let's pay attention to the table. That's where most of the questions are likely to come from. So in this table, you have several variables. On the first column, you have numbers reported, numbers per group, numbers in each group divided by total number of people, and then a percentage is also given. You also then have crude ratios of crude odds ratios, OR, crude values are given, followed by 95% confidence interval for each of this variable. So they are looking at the relationship between each of these socioeconomic variables and common mental illness. And that relationship, the strength of the relationship is depicted using odds ratio. Strength of association is inferred using odds ratio. They've given you a confidence interval as well. And then they have also given adjusted ratio, and they've given adjustment for a certain set of variables in model 1, says model 1, and there are adjusted odds ratios followed by 95% confidence intervals. Okay, so these are the data that you got given in your exam. What questions have been asked? First question, the above study follows which of the following study designs? Case control, cross-sectional, prospective cohort, ecological study, retrospective cohort. So let's examine the information given in the text. We see certain keywords here. We see that to investigate the longitudinal association between socioeconomic position and common mental disorders in a general population sample, data from psychiatric morbidity survey was used. Sample included adults living in private households. Main fieldwork took place between March and September 2000. Interviews were available for 8,580 interviews. 18 months later, 3,500 of the original respondents were contacted for a follow-up interview, and 2,406 were successfully re-interviewed. So you start a study and then you follow people up for a specific purpose, that is to re-interview them and ask them about mental health, persons of common mental disorders. So this is a prospective cohort study. You start from people who are in a survey, Office of National Statistics survey, and then you follow them up for around a period of 18 months after inception. An inception cohort being followed up. This is a prospective cohort study. Which of the following can affect internal validity of the study? Use of CSIR, definition of socioeconomic status, prospective design, the attrition rate, the sampling frame. So which of the following can affect the internal validity? Now let's see what internal validity actually means. There are two types of validity that you can infer from a clinical trial, internal and external validity. Internal validity answers the question, to what extent does the study allow us to attribute observed effects to the manipulation of the independent variable? So you have two groups, active intervention group and the placebo group, and you compare them, you see a result. To what extent is the result that you observe is because of the separation between the two groups? So in other words, how much can you trust the relationship between the exposure, the intervention here, and the outcome that is reported from your study design? So you have to have a very well conducted study without any selection bias, without any measurement bias, in order to have a good degree of internal validity. So this is called internal validity. So things like attrition, high attrition rate can cause selection bias, can actually differentially affect the two groups, cause a selection bias, and this bias can affect internal validity. So it's important that we control the attrition rate that can affect the internal validity of a prospective cohort study, prospective cohort or a randomized controlled trial. Which of the following can affect the external validity of this cohort? Use of CSIR, socioeconomic status definition, prospective design, attrition rate, sampling frame. What is external validity? External validity answers the question, to what extent can we generalize the study findings to other people or other settings? So it is about generalizability. how confident can we be on the representativeness of the sample's results to the population. So if you have done sampling properly, if you have used an exhaustive sampling frame that captures and represents most people in the population, then your external validity will be very good. So the degree to which a study is free from study-specific parameters that alienate it from the real world, that's called external validity. So the sampling frame, the quality of the sampling frame, the size of it, the way it's defined, all of that will affect the external validity. The answer is sampling frame. What is the unadjusted odds ratio for developing a common mental disorder in those who have financial difficulties compared to those who do not? So we now have to look at the people who have financial difficulties as the exposure. We have to find out what is the risk of developing common mental disorder. So let's look at the table here. Where is this information on people who have financial difficulties? It's here. Can you see that? Any financial difficulties? No, and then yes. So people who have financial difficulties is yes, and you see a crude ratio of 2.53, and that varies between 1.59 and 4.04. So that's the unadjusted crude odds ratio, and that's 2.53 for people who have financial difficulties compared to people who do not. Next question, why is the odds ratio for a common mental disorder for those who have a degree as educational qualification is 1? Having a degree as qualification prevents development of mental disorders. Those who have a degree had 100% participation rate. Those who had a degree had no financial strains. People in other education groups were compared to those who have had a degree. While 50% of those with a degree remained well, 50% developed a mental illness. So that's why the odds ratio is 1. So which of the following is correct then? Look at the odds ratio here for degree as educational qualification. You see that's 1, and there are no confidence intervals. In other situations you have values given and confidence intervals given, but here it's only 1. We can see that kind of anomaly, having values 1 but no confidence intervals, also for no financial difficulties, also for full-time employment, also for male gender, also for age being 16 to 24. Okay, so why is that so? Odds ratio of 1 in the table indicates that this group serves as the comparator against which the other group has been compared. So in this case, educational qualification, if you have a degree, you are the comparator and everybody else is compared against you. Who are the everyone else? People with A-level education, GCSE or equivalent, and no qualification. So these are all compared against people who have a degree. So the correct option for this question is people in other educational groups were compared to those who have had a degree, Okay. Looking at the above table, which of the following statements are true? Subjects are more likely to develop a common mental disorder if they are in the age group 45 to 54. There is a statistically significant relationship between age greater than 65 and development of common mental disorder. Presence of financial difficulties is not associated with common mental disorders. There is a statistically significant relationship between being a woman and common mental disorders. Part-time employment protects against common mental disorders. So what can we conclude? Let's look at the table. This table, can you see socio-demographic variables between age 65 and 74? Odds ratio is actually less than 1 and it is significantly less than 1. Okay, so people who have who are in the age group 65 to 74 actually have a lower odds, lower risk of having a common mental illness. The confidence intervals of adjusted rates do not cross the point of no difference for the age group 65 to 74. So this age group has less risk of common mental disorder. So we can conclude statement true is correct. There is a statistically significant relationship between age greater than 65 and development of a common mental disorder. Okay. All other statements are false. Subjects are not more likely to develop a common mental disorder in the age group of 45 to 54. Financial difficulties was associated with mental disorder, so this is also false. The statistically significant relationship between being a woman and common mental disorder is false as well. Part-time employment protects against common mental disorder is also false. So you can look at those tables to see why these are false. Part-time employment, we don't see any results here because it's the comparator. Okay, and when it comes to being a woman, gender, and presence of financial difficulties, okay, so gender, female, is not significant. Okay, and even after adjustment it's not significant. And for financial difficulties, having the difficulties has has actually increased the risk. So that's true. So it doesn't reduce the risk. It is associated with common mental disorder. So C is false. It is not associated as the statement, so it's false. So the only statement that is correct is, as I have told you before, it's statement B. There is a statistically significant relationship between age greater than 65 and development of common mental disorder. We've examined everything else and all of the other statements are false. In the above table, which of the following statements regarding material standard of living is the most accurate interpretation? In the above table, which of the following statements regarding the material standard of living is the most accurate interpretation? A. There is no association between standard of living and common mental disorders. B. The association between standard of living and common mental disorders becomes more prominent after adjusting for other variables. Confounders affect the association between standard of living and common mental disorders. Using standard of living score, the sample is classified into two groups. The proportion of those with poor standard of living is same as those with good standard of living. So let's look at the standard of living item. Can you see the material standard of living score here? It is not split into two. It's not two categories. It's only one item here, material standard of living score. You don't have a yes or no subtypes. You have only one. That's because this is a continuous score. So there is no comparator. They've just related the score as it is with the presence or absence of common mental disorder. For continuous outcomes, you don't need a comparator. Only for categorical outcomes, you need a comparator. Only for categorical variables, you need a comparator. Okay. So what is the reported result? 1.27 is the crude ratio, crude OR. And is it significant? Yes. Crude value is significant. It's between 1.11 and 1.45 is the confidence interval. Because the confidence interval, both lower and upper limits of the confidence interval is above 1, this is a significant result. What happens after adjustment? This is the adjusted result. You see the result is 1.20 now, but it loses its significance. The confidence interval limits become 0.96 to 1.49. So the lower limit is less than 1, the upper limit is higher than 1. This sort of asymmetry indicates significance is lost. Okay, so if crude rates are different from adjusted rates, especially if the significance is lost on adjustment, this suggests that the confounders are influential. So can we choose choice C here? Confounders affect the association between standard of living and common mental disorders. That's what we see using the two columns in the table.